Bismillah ar-Rahman ar-Rahim. Today we shall discuss an important topic, which is epilepsy. Epilepsy is relatively common. It's found in nearly 1% of the population. But before we start the lecture, we need to define what is epilepsy and what is seizures. When a group of neurons abnormally, excessively discharge in a synchronized manner, giving symptoms in the form of disturbance of consciousness, change of behavior, autonomic changes, motor changes, sensory changes, or any combinations of these, this will cause what we call a seizure. Seizure must be paroxysmal, having sudden onset, sudden offset, short duration, and tendency to recurrence in a stereotyped manner. A single seizure is a symptom, but the recurrence of seizures without a provocation, this is called epilepsy. So epilepsy is recurrent, unprovoked seizures. So let us define what's provocation. Provocation means we have a provoking factor. This provoking factor must be the direct cause of the event. For example, if we have febrile convulsions, fever is a provoking factor, and convulsions is the resultant symptom. If we have 10 times the patient has convulsions, 9 of them was associated with fever, but 1 of them was not associated with fever, we don't call this provoked seizure because 1 of them was not associated with seizure. So we call this epilepsy because 1 of them is not associated with a provoking factor. So for a provoking factor, every event that occurs must be associated with the provocation. Number 2, there must be a temporal relationship. That is to say, when the provoking factor occurs, there is no temporal lag, no time lag between the provoking factor and the event itself. So if we have a head trauma, for example, and after 6 months we have a seizure, we don't call the trauma as a provoking factor for seizure. But if this is recurrent, we call this post-traumatic epilepsy because this is not a provocation. Provocation means there is no time lag between the provoking factor and the event. So after definition, we need to go deep into the subject of epilepsy. If you are confronted with a patient with epilepsy, you have many questions in your mind that needs to be answered. The first of them, is this epilepsy or not? What the patient described, is this seizure or not? So we have many mimics of seizures. Number 1 of them is psychogenic pseudoseizure. We need to differentiate between psychogenic pseudoseizure and the true seizure. The psychogenic pseudoseizure usually is preceded by emotional trauma or emotional stress. Seizures may not be associated with emotional stress at the onset, and the patient may have a seizure while he is sitting alone. Even more, he may have his seizure during sleep, but this doesn't occur in psychogenic pseudoseizure. Psychogenic pseudoseizure, emotional trauma, the event occurs in front of others, so the patient is not alone and doesn't occur during sleep. The patient with true seizure passes into 2 phases. The tonic phase, during which there is continuous contraction of all the muscles of the body. Then clonic phase, during which there is repetitive contraction and relaxation of all the muscles of the body. So passing through the tonic phase, which usually lasts for less than 30 seconds, will lead to contraction, sustained contraction of all the muscles of the body including the laryngeal muscles, the respiratory muscles, the diaphragm, so the patient will not have proper respiration. This will lead to hypoxia. So the patient will experience cyanosis. Cyanosis is evident only in true seizures, but never occurs in psychogenic pseudoseizure. Then the patient passes into clonic phase, during which there is repetitive contraction and relaxations of the muscles of the body, all the muscles of the body, including the muscles controlling the jaw, the temporalis and the masseter muscles. This will lead to tongue biting with blood-tinged frothing coming out of the mouth. This occurs in true seizure, but never occurs in psychogenic pseudoseizures. Then the patient have during the clonic phase repetitive contraction and relaxation of the abdominal muscles, leading to evacuation of the bladder with self-wetting. This occurs only in true seizures, but never occurs in psychogenic pseudoseizures. Repetitive contraction and relaxation of the abdominal muscles will lead also to evacuation of the rectum with self-soiling. This occurs only in true seizures, but never occurs in psychogenic pseudoseizures. The repetitive contraction and relaxation may lead to injury of the patient. He may have shoulder dislocation. He may have self-injury during the contraction and relaxation with cut wound or whatsoever, lacerations. This occurs only in true seizures, but never occurs in psychogenic pseudoseizure. And at the end of the event, the true seizure usually ends by confusion, headache, tendency to sleep, exhaustion. But in psychogenic pseudoseizure, the end of the pseudoseizure is usually by crying, kicking, laughing, emotional event at the end as it starts. So we have many differentiating points between psychogenic pseudoseizure and the true seizure. Let us revise them. Number one, the emotional charging at the start. Number two, tongue biting, self-wetting, self-soiling, self-injury. So these are very important differentiating points. Cyanosis is very important also. The duration of the psychogenic pseudoseizure is usually longer, but in the true seizure usually lasts less than 2 minutes. So if we ask the patient and the family about the history and the points I have mentioned now, we can differentiate easily between psychogenic pseudoseizure and the true seizure. The second mimic of the true seizure is what we call syncope. So what is syncope? It is transient loss of consciousness due to transient global hypoperfusion. Let us revise the hypoperfusion, and the brain is very sensitive to hypoxia and hypoglycemia. So if the part of the brain is temporarily deprived from the blood supply, we call this transient ischemic attack, TIA. If a part of the brain is persistently deprived from the blood supply, this will lead to ischemic infarction. If the whole brain is deprived from the circulation for a very short period, this will lead to what we call syncope. If the whole brain is deprived from circulation for long duration, this will lead to brain death. So the brain is very sensitive to hypoxia and hypoglycemia, and any decrease in the circulation, whether focal or generalized, will lead to symptoms which have devastating effect on the long term if left untreated. So if we have transient global hypoperfusion to the brain, for example, a patient with arrhythmia, for example, vasovagal attack, for example, this will lead to relative bradycardia with decreased cardiac output, that will lead to cerebral hypoperfusion. All of these will lead to cerebral hypoperfusion, and secondly, it will lead to syncope, which is transient loss of consciousness. After loss of consciousness, the patient fall to the ground, and then the effect of the gravity will lead to better circulation to the brain. So reperfusion to the brain will get the patient aroused, and he will wake up and will complete what he was doing. So what are the differentiating points between syncope and the true seizures? In syncope, the patient experiences some symptoms related to the sensitivity to hypoxia. So what is the most sensitive part of the head to hypoxia? It is the retina. What is the second most sensitive part of the head to hypoxia? It is the vestibular system. What is the third most sensitive part to hypoxia? It is the reticular activating system. So the patient with syncope will experience symptoms in a sequential manner. Number one, he will have blurring of vision due to the hypersensitivity of the retina. Then he will have giddiness and swinging to the right and left due to the hypersensitivity of the vestibular system. Then he will have loss of consciousness due to the hypersensitivity of the reticular activating system. He will fall down to the ground, and the anti-gravity effect against the flow of the blood in the cerebral circulation will be lost, and the patient will lie flat. So better circulation will be regained, and the patient will stand up, terminating the syncopal attack. So it is very short-lived. It occurs in seconds, while the patient with seizure usually have 1 to 2 minutes to experience the attack. So the duration is very important. Even more, the syncope is associated with hypoperfusion of the head. So the face of the patient will show pallor, while the patient with true seizure will have cyanosis. The patient with true seizure will have tongue biting, self-wetting, self-soiling, but this doesn't occur in syncope. The patient with true seizure have post-ictal confusion, post-ictal headache, post-ictal tendency to sleep, but this will not occur in syncope. The patient with syncope after the end of the attack will regain what he was doing before. He will complete the action he was doing before. So it's very short-lived. It doesn't interrupt the activity of the patient. So this is syncope, which is very, very short-lived. It's important to differentiate between them, because if the patient have arrhythmias, for example, and you are diagnosing him in a wrong manner as epilepsy and give him anti-epileptic drugs, some of these anti-epileptic drugs may increase even the arrhythmia and will cause the syncope to occur more frequent, and more injuries to the patient will be experienced. So very important to differentiate between the two events. So after diagnosing the seizure and excluding the other causes that simulate seizures, we have a seizure. So the second question is, what is the type of this seizure? We have two main types of seizure. Number one, generalized seizures. Number two, focal seizures, that was previously called partial seizures. Generalized seizure is associated with complete loss of consciousness. Complete loss of consciousness. This is very important to differentiate between generalized seizures and focal seizures. Focal seizures is subdivided into two components. Number one, with clear awareness, during which the patient is responsive to the environment and having very good memory to the event. Number 2, focal with impaired consciousness, impaired awareness. These patients will be somewhat confused and responsive to the environment, but the response is not so appropriate. And after the cessation of the focal seizure, you will not remember what happened during the attack. So there is two types of focal seizures, with impaired awareness and with clear awareness. Either of them may be manifested by motor change or sensory change, autonomic changes, or psychobehavioral changes, or any combination of them. Generalized seizure, on the other hand, is associated with complete consciousness, loss of consciousness. I have described in the last few minutes what is tonic-clonic seizures. This is the most important and prevalent type of generalized seizure that is experienced worldwide. It is called generalized tonic-clonic seizures, during which the patient passes into two phases. Phase 1 is tonic phase, during which there is sustained contractions of all the muscles of the body. Usually it is associated with cyanosis. Then he passes into another phase, which is clonic phase, during which there is repetitive contraction and relaxation of all the muscles of the body. Usually it is associated with tongue biting, self-wetting, self-soiling, and self-injury. One type of seizure, in addition to this generalized tonic-clonic, is experienced by few patients during which there is only tonic phase. We call these tonic seizures. So we have generalized tonic-clonic seizures, we have generalized tonic seizures, and even we have generalized clonic seizure, during which the patient experiences only the clonic phase. So we have three types: generalized tonic-clonic, generalized tonic, and generalized clonic. We have a very subtle type of seizure, during which the patient just have lapse of consciousness. If he is talking, he will interrupt the speech for a few seconds and then complete the speech as if he was not doing anything in between the two events. This we call absent seizures. He is absent from the environment for few seconds, and the patient is unaware that he was absent during this period. We call this absent seizures. The patient doesn't lose the muscle tone. He will maintain the erect position during the attack. But if he loses the muscle tone and fall to the ground during the absence, we don't call it absence, we call it atonic seizure. So atonic seizure is very similar to absence, but associated with loss of postural tone. We have another type of generalized seizure, which is called myoclonic seizure. Myoclonic seizure is one type of seizure during which the patient experiences sudden, vigorous, shock-like movement of the muscles of the body, mainly around the shoulders. This myoclonic seizure is associated with cortical, abnormally active discharges that differentiate it from the non-epileptic myoclonus, which is one of the involuntary movements. So we have many types of generalized seizures: generalized tonic, generalized clonic, generalized tonic-clonic, absent seizures, atonic seizures, and myoclonic seizures. All of them are associated with complete loss of consciousness. But the last one, which is the myoclonic seizure, is very short. It occurs in less than half of a second. So the patient have no time to lose consciousness. So this is the only type of generalized seizures which is not associated with complete loss of consciousness if it occurs in singulets. That is to say, if the patient have a single myoclonic seizure, he will not lose consciousness. But if myoclonic seizures occurs in clusters repetitively, this will affect consciousness definitely. So that's why it is put under the term of generalized seizure. So when you have a question, what is the type of the generalized seizure that is not associated with loss of consciousness? The answer is myoclonic seizure. So after classification of the seizure types, we need to know the third question, which is what is the cause of this seizure? So as I told you, the cortical neurons, a group of cortical neurons, a large group, we call it a population of neurons, abnormally, excessively, and in a synchronized manner, discharge giving the symptom. So what irritates these cortical neurons? Either a local factor in the brain or a systemic cause that disturbs the environment around these cortical neurons. Local factor in the brain like what? Acute event, acute inflammatory process like encephalitis or meningitis. Vascular event like hematoma, subarachnoid hemorrhage, subdural hematoma, ischemic infarction, venous infarction. Trauma, brain contusion, subdural hematoma, epidural hematoma. Neoplastic, meningioma, gliomas, and many others. Even degenerative processes of the brain may irritate the neurons, giving some seizures. So after the causes being local, we have systemic causes like systemic hypoxia, like hypocalcemia, like hyponatremia, like end organ failure like uremia, like liver failure. All of these will disturb the environment and around the neuron, giving systemic causes of seizures. However, more than half of the patients have no any cause that can explain the seizures. So after full investigation, we don't find any cause for 50% of the patient. So what is the cause for this 50% of the patient? It is the hereditary predisposition to have recurrent seizures unprovoked. We call this the hereditary predisposition to have unprovoked seizure. We call it idiopathic epilepsy. So we can classify the causes into idiopathic and symptomatic. Idiopathic, we have no known cause except the genetic susceptibility to have the disease. And the symptomatic or secondary causes are subclassified into local causes in the brain and systemic causes in the circulation. When you are confronted with a patient with epilepsy, you need to answer the question, is this idiopathic or generalized? Or symptomatic, sorry. Is it symptomatic or idiopathic? To differentiate between them, we have some clues that helps. Number one, the age of onset of the seizure. Usually the idiopathic starts before the age of 25. So any patient that have his first seizure after the age of 25 must be considered secondary or symptomatic till otherwise is proved. Number two, the neurological examination. If you are examining the patient and the patient has neurological signs, hemiparesis, ataxia, whatsoever, you should search for symptomatic causes. Number three, the presence of mental retardation or deterioration. If the patient have cognitive changes, recent cognitive changes related to the onset of seizure, you should consider this symptomatic till otherwise is proved. So we have idiopathic and symptomatic causes. Sometimes the patient has the clues to have symptomatic causes, and we investigate all the possible investigations, searching for the cause, and we find nothing. If you find nothing after full investigation in a patient supposed to have symptomatic seizure, we call this type cryptogenic. So cryptogenic is usually symptomatic, but the investigation didn't reveal the actual cause. We have three types of causes: idiopathic, symptomatic, and cryptogenic. After identifying the cause of the seizure, we need to speak about the investigations. Number one, the EEG. The EEG is a machine like the ECG that magnifies the signals coming out of the cortex through electrodes applied to the scalp, 21 electrodes applied to the scalp, arranged in a certain manner, well defined, recognized all over the world system of applying these electrodes to the scalp, recording the electrical activities coming out of the postsynaptic potentials coming from the cortical neurons, and these very small amplitude signals are amplified to be displayed on a machine. We call this EEG machine or electroencephalogram. Actually, this machine is very helpful because it is the only real life recording of the event. If you can image the patient even during the attack, the brain will not show any anatomical changes. But the physiological changes that occur, that become pathological at that time during the seizure, can be recorded by this machine, which is called electroencephalogram. Even more, in between the attacks in the epileptic patients, more than 60% of them will show abnormalities, which is specific for epilepsy. We call these epileptiform abnormalities. But during the attack, the epileptiform abnormalities that occur during the attack are much more specific and sensitive for detecting the epileptic attack. So if we apply the machine and the patient experience an attack during the recording, this is specific and sensitive to the disease, and it's very diagnostic. If we apply the machine in between the attacks, we have 60% accuracy for diagnosis, but 40% will be missed. And even more, a certain amount of the population, around 2.5% of the population, have these interictal changes or epileptiform abnormality that occurs in between the attack. We call it interictal changes. So we may misdiagnose these normal healthy persons as epileptic. So we cannot rely on the interictal epileptiform abnormalities for diagnosis. Only we should rely on the ictal or the recording during the attack, which is very rare. So being very rare, we don't rely on the EEG for diagnosis. Only we rely on the history. So history is the most important tool for diagnosing epilepsy. EEG is helpful, confirming the diagnosis, classifying the seizure type, answering some questions like when to start the anti-epileptic drug, when to terminate anti-epileptic drug, and it helps a lot in the localization of the focus in pre-surgical assessment. So it's very important to know the limitations and the benefits of the EEG. Regarding the investigation for a patient with epilepsy, we can use MRI. MRI will be very helpful for identifying the cause when we have a local cause. For example, we have a brain tumor or infarction or hemorrhage whatsoever. MRI will be very helpful. It is even more helpful than the CT. CT brain may be helpful, especially when we have hemorrhage or calcification in the brain. Other tools may be helpful for investigation, like lab tests. If we are suspecting hypocalcemia or hyponatremia whatsoever, lab test may be very helpful. CSF examination is only used when you are suspecting meningitis because it's very diagnostic for this disease. So we have many investigations to be used in a patient with epilepsy. None of them is diagnostic. They are helpful in the diagnosis and are helpful in identifying the causes for the seizures. So after diagnosing and after investigation, we need to start treatment. If the patient have a single unprovoked seizure, we don't call this epilepsy because epilepsy is recurrent unprovoked seizures. So we don't treat single unprovoked seizure. If the patient has recurrent provoked seizure, we don't treat them with anti-epileptic drugs because provoked seizures are not epilepsy. We deal with the cause and so we will prevent the seizures. If the patient has recurrent unprovoked seizure, we shall start anti-epileptic drug. The choice of the anti-epileptic drug depends on many factors. The most important of them is the seizure type. For example, if you have seizure type like focal seizure, some drugs are more preferable, like phenytoin, carbamazepine, oxcarbazepine. And if we have one type like absence seizure, one drug is very important and helpful, which is ethosuximide. Valproate may help. And for generalized seizures, all types of generalized seizure, sodium valproate is the best. However, each of these drugs have its own side effect profile that limit our use of them. We have some other drugs that are wide spectrum and is used in all types of seizure but have their own side effects. Levetiracetam, topiramate, and zonisamide and others are used for most types of seizures. When selecting a proper anti-epileptic drug, you should try it for at least 2 months. If seizure control occurs, the patient should be maintained on the least effective dose to minimize the side effects. Usually we start with low dose and increase it gradually to reach the desired dose which within the therapeutic range of the drug. If the patient is not controlled within 2 months, we should try another drug for another 2 months. If the second drug fails also, in spite of proper choice, we can choose a third one or we can combine 2 medications. This third trial lasts also for 2 months. After the third trial, usually the patient will not make any benefit from further trials. So don't try fourth trial or fifth trial or sixth trial whatsoever, because they will not help anymore. So what is the solution? How to resolve this problem? The patient fails to respond to three trials of properly chosen anti-epileptic drugs. We have many options at that time. Epilepsy surgery come on the top, especially for focal seizures. When you can identify the focus, we can resect this focus, especially when it is away from the eloquent brain. The second line, which is called ketogenic diet. This type of diet, we don't use carbohydrate, we use only fat as a sole source of energy. This type of diet changes the environment around the neurons, and this helps in interrupting the synchronizations of the abnormally discharging and excessively discharging neurons, and this will lead to seizure control. So ketogenic diet will help 1/3 of the patient with intractable seizures will get their seizure free, and another third will have their seizures reduced, and the third one will not make benefit of the ketogenic diet. So we have epilepsy surgery, we have ketogenic diet, and we have a third option, which is neurostimulation. When you stimulate the cerebral cortex very near to the epileptic focus, this disturbs the propagation of the seizure and limits its propagation, and this will lead to cessation of propagation of the impulses and will abort the seizure. We can use local stimulation implanted in the brain itself, or we have retrograde stimulation through the vagal nerve. So we have vagal nerve stimulation. This is another option for decreasing the frequency of the attacks. So we have three options for patients with intractable seizures, which are defined as failure of 3 trials of properly selected anti-epileptic drugs, each of them lasting for 2 months. And we have known how to choose the anti-epileptic drug. The suitable profile of the anti-epileptic drug is very important, especially the seizure type and the side effect profile and the cost, because some of the anti-epileptic drugs are expensive and the patient should take them for very long duration. The last portion of the lecture is describing the most important point, which is the status epilepticus. So what is the status epilepticus? It is prolonged seizure. So why the seizure is not prolonged? Normally, the seizure have its own mechanism of termination. We have some spinous interneurons that secrete inhibitory amino neurotransmitters, mainly the GABA and the glycine, over the area that discharge excessively and abnormally and in a synchronized manner. So this will take the seizure into its termination. So we have our own termination system designed by Allah subhanahu wa ta'ala, and this is very important in seizure termination. If this termination system fails at any moment, the seizure will persist. And the persistence of the seizures will get some of the cytokines overexpressed and more available in the media of the neuron themselves, causing structural injury to the neurons and irreversible damage to them. And this is the most important point. If we have irreversible damage to the neurons, the patient, even on termination of the seizure, will not get back to normal. So this is hazardous to the patient. So we should prevent the patient from reaching this point. We have 2 points to be annotated. Number one, T1. It's one point at the timeline of the seizure occurrence. It is the time after which the seizure will not terminate. We call this T1. So T1 is the time usually when the patient passes over it, the seizure will not terminate. For the generalized tonic-clonic seizure, this T1 is 5 minutes. So if a patient has a seizure lasting for 1 or 2 minutes, it may terminate. 3 minutes, it may terminate. 4 minutes, it may terminate. But after 5 minutes, usually, it will not terminate. So you have to take action. If we don't take action for half an hour, which is T2, structural and damage will occur to the neurons. This irreversible damage will occur after the time we call it T2. So T2 is the time after which irreversible damage to the neurons will occur. So it's important to protect the patient in terminating his seizure before reaching this point. So any patient with a single prolonged seizure lasting for a duration more than 5 minutes, you should take action because usually it will not terminate, and we should consider this status epilepticus. But sometimes the patient may have a seizure lasting for more than 5 minutes or 3 minutes whatsoever, and after which there is exhaustion of the muscles, leading to the seizure to occur only on electrical base, not in a clinical manner. So you will not detect the seizure if you are examining the patient. But this patient having his seizure going on without evident clinical correlates. So if you have patient with recurrent seizures without intervening regaining of consciousness, this patient may have status epilepticus, and during part of this status epilepticus, the patient exhibit no motor symptoms. So for any patient with recurrent seizures for a duration more than half an hour without regaining of consciousness in between the attack, we should consider this also as a status epilepticus. So the definition of a status epilepticus is either one of two: prolonged seizure lasting for a duration more than 5 minutes, or recurrent seizures without regaining of consciousness in between, lasting for a duration more than half an hour. What is the most common cause of status epilepticus? The most common cause of status epilepticus is sudden drug withdrawal due to non-compliance of the patient. This is very important. So awareness for the patient and the family is crucial in preventing status epilepticus to occur. Status epilepticus is one of the medical emergencies because it can lead to death or severe mental sequelae due to the irreversible brain damage. Just by explaining to the family how important to comply with the drug will prevent a lot of the cases of the status epilepticus. However, we have other causes of status epilepticus, including CNS infection, including metabolic changes like hyponatremia or hypocalcemia whatsoever, head trauma, and many others will lead to status epilepticus. When you are confronted with a patient with status epilepticus, what to do? Let us start by the ABC. So, clearing the airway is very important because most of the families will put handkerchief inside the mouth to prevent the patient from tongue biting. And this is very wrong and very bad habit because it obstructs the airways. The patient will get cyanosis due to the handkerchief obstructing the oropharynx, and this is very hazardous. So at first you have to remove anything inside the mouth. Clear the airways, please. Number 2B, which is breathing. Look at the saturation and give the patient oxygen if he is in need. Number 3 is C, which is the circulation. So you have to measure the blood pressure and look at the perfusion for the patient, and if he is hypoperfused or hypotensive, please infuse with saline or Ringo solution to get better perfusion. And then we should have 2 lines, one in the right upper limb and one in the left lower limb. 2 cannulas will be applied for the patient. One of them we shall give diazepam or lorazepam. Diazepam or lorazepam will start action immediately within 30 seconds, terminating the seizure. So it's important to start with this drug. In the other line, on the other hand, we shall give phenytoin. We give phenytoin at a very low rate. Phenytoin will start action after half an hour, and its action will last for 1 day. The diazepam we have given will start action within 30 seconds, and it will terminate after 30 minutes. So its action will last only for half an hour. On the other hand, phenytoin will start after half an hour, lasting for 1 day. So giving the 2 drugs, each of them at 1 cannula, we will get seizure freedom within 30 seconds, lasting for a duration 1 day, which is very good for us. Let us discuss the doses. Diazepam will be given at a dose of 10 milligrams. It can be repeated after 5 to 10 minutes if the patient is still seizing, and to be repeated another time if the patient is still seizing. So we have only 3 trials of diazepam. Phenytoin will be given at a dose of 1000 milligrams, which is loading dose. The point in phenytoin is that it is cardiotoxic, causing hypotension and bradycardia. But these side effects are rate related, not dose related. So if you give phenytoin, whatsoever the dose, at a very low dose, at a very low rate, you will not get toxicity of the drug. But if you give the 1000 milligrams in one shot, the patient will have severe bradycardia and hypotension, which is not permitted in this case. So please infuse the phenytoin over a duration of 20 minutes or more. This is very important. If we apply the same drugs to the children, we give the diazepam at a dose of 0.1 to 0.3 milligram per kg in each trial. And phenytoin, we give it at a dose of 16 to 20 milligram per kg as a loading dose. So it's very important to give the diazepam immediately and to give the phenytoin slowly. We have another type of phenytoin which is called phosphatoin, which is much less cardiotoxic. We can give it over a duration of 7 minutes only. It's rapidly acting. So it's not available in Egypt. We use usually the phenytoin, which is very effective but needs this precaution. If the seizures persist in spite of these measures, we call it refractory status. We either use second line drugs like valproate, levetiracetam, phenobarb, or lacosamide. These drugs can be used intravenously in case of failure of the previous measures. So the previous measure lasts for half an hour to 1 hour maximum. The second one will have another half an hour. If within 1 hour is still the patient seizing, should apply endotracheal tube and mechanical ventilation is needed. At this point, we use general anesthesia for the patient to suppress the electrical activity that will cause damage to the neurons. We use propofol continuous infusion or midazolam continuous infusion, or we can use one of the barbiturate products, sodium cypentoad sodium or pentobarbital. Either of these measures will suppress the seizures, but the patient must be intubated and on mechanical ventilation. We maintain these drugs with, after control of the clinical seizure, we should have EEG to make sure that the patient have also seizure freedom in the EEG. If the patient have no electrical activity in the EEG and no clinical event, so the seizures are called to be well controlled. The patient of this refractory type of seizure must have a well-controlled seizure for at least 12 hours before weaning from the ventilator and the intravenous anesthetics. It's very important to know the basic A, B, C, D, E before studying the refractory type, which is usually done by the specialist in the ICU. So don't forget A, airway, B, breathing, C, circulation, D, diazepam, and E, which is epanotin, standing for phenytoin, which is the trade name for the phenytoin, epanotin, 1000 milligram as a loading dose. Thank you very much for your attention, and meet you in the Zoom meeting, inshallah.